So we're going to move on now and start talking about BPH. We are going to try to accomplish this in basically hopefully 30 minutes or less. We're not going to make it too complicated. So we're focusing on the male reproductive system at this point. You are paying attention to the structures like the urethra and also specifically the prostate gland. All right, so you see how the urethra comes all the way up this way, right? So what happens is if the prostate gland basically becomes too big or enlarged, you're getting constriction of the urethra, and that is the problem. So BPH is enlargement of the prostate gland, and it basically leads to disruption of urine outflow from the bladder to the urethra. Apparently, about 50% of men will have signs of BPH by the age 50, and then 70% by ages 60 to 69. And the symptoms that you're going to get are basically being described as lower urinary tract symptoms, and they'll either describe them as being irritative or being obstructive. So you don't have to memorize whether they're irritative or obstructive. Just be familiar with what the symptoms look like. All right. So some of these symptoms include difficulty starting a urine stream, decreased weaker flow of urine, and problems basically with urinary frequency. BPH is not completely understood. So they're thinking that a lot of it has to do with the aging process and the different changes that can happen with the hormones, right? So specifically, we're talking about DHT. So DHT is a sex hormone, and it basically stimulates the prostate to grow, right? So that's a natural process. You know, a young boy becoming a man, all of that is normal. But what happens in older men is that you're getting an excessive accumulation of DHT in the prostate cells. So then you're getting this huge hyperplasia basically of the prostate. The other issue that they're thinking is that the patient ends up with too much estrogen. As the patient gets older, you're getting increased amounts of estrogen over the testosterone, and unfortunately, increases in estrogen actually lead to increases in DHT. So therefore, that also contributes to the fact that the prostate tissue now becomes bigger. So this is the reasoning behind it. So the particular area where the BPH happens is known as the transition zone. Don't have to memorize that, just know that it's out there. So the issue, like I mentioned earlier, was that as the tissue basically enlarges, it compresses the urethra. So what you end up with is either a partial or complete obstruction, and then the patient ends up with particular clinical manifestations. There is no direct relationship between the size of the prostate, growth, and the severity of the symptoms that the patient ends up with, right? So some patients may have a really huge and enlarged prostate, but they may actually end up with very minimal manifestations. And somebody may have a smaller amount of growth, but then they may end up with really bad manifestations. So apparently the location is the bigger issue at the end of the day. So here you're just seeing a picture of a compressed urethra. All right, so there's BPH issue there, and then the urethra is basically being compressed, right? And then the whole issue is you have your bladder here as well. So if there's compression and this urine is supposed to be coming out, it's not able to do any of that. So that leads to a whole bunch of other problems. So remember, urine is supposed to be going forward. That's no longer happening. So imagine where the urine is coming from and everything is backing up. What are the potential complications that can happen? So this is just views of the prostate. So A is actually the normal, and then here in B you're seeing the abnormal prostate. So it's a moderate amount of BPH, and there's urethral obstruction that's happening. So you want to be familiar with your risk factors for BPH, all right? So we've already mentioned things like aging, obesity, lack of physical activity, alcohol use, erectile dysfunction. smoking, diabetes, family history, especially if the patient has a first-degree relative. So don't fight with the risk factors. This is just what they're finding. They've done studies and they're finding that these particular patients are the ones that may be more at risk for BPH. Your clinical manifestations occur gradually. So early on, the bladder may initially compensate for small amounts of resistance to urine flow. All right. Unfortunately, as the obstruction gets worse, then the symptoms also are going to become worse. So as I mentioned earlier, they're describing them as either irritative or obstructive. For your purposes, you are just going to know what these symptoms look like. So you don't have to necessarily differentiate between irritative versus obstructive. But this is really easy. This is stuff like basically urinary outflow types of problems, right? Or UTI types of manifestations even. So things like nocturia, urinary frequency, urgency, dysuria, bladder pain, incontinence, and then things like decrease in caliber and force of urinary stream, difficulty initiating a stream, so starting and stopping several streams several times, avoiding, and dribbling. All right, so just be familiar with what the clinical manifestations look like, and you do not have to differentiate between irritative or obstructive. They have a symptom index for BPH that they use. So it's a couple of questions. Basically that they ask the patient. So it's not diagnostic, but it does provide some guideline for treatment to see how bad the BPH is. So 0 to 7 is considered mild. So you can look at the table. You don't have to memorize it once again. But 0 to 7 would be considered mild. 8 to 19 would be considered moderate. And then 20 to 35 would be considered severe. So at the very least, like know that, if I said to you somebody had 0 to 7, on the AUA, you would know that that was mild. And if I said they had 20 to 35, at least you would know that that was severe. But you don't have to memorize the questions or anything like that. You can just look at them. So in terms of the complications of BPH, apparently they're pretty rare. But if they do happen, you're going to see things like, things like acute urinary retention, sudden and painful inability to urinate, right? So treatment for that actually is, catheter insertion or surgery if it's severe. So you're going to see a whole bunch of different types of surgeries that they can do. The one that I want you to focus on is the TURP, because that is still considered the gold standard. So I left all the other different types of minimal or invasive types of surgeries just as a reference, but you are focusing on TURP. So the other complications that you may see, include things like UTI. This is primarily because of an incomplete bladder emptying, and you're getting the residual urine that's there. So that issue is you're going to get the bacterial growth that happens. So if the bladder is really, if the urethra is really blocked and urine is not flowing, then you're going to see some of the worst things that can happen. So things like pyelonephritis, sepsis, bladder calculi, and if it's really, really severe, then you're seeing things like renal failure because of the hydronephrosis and all the bladder damage that potentially can happen. So once again, our takeaway is that it's pretty rare in terms of complications, but if it does happen, it can be pretty severe. There's a whole bunch of different types of diagnostic studies that they can do. So just know that these are out there. I will highlight the digital rectal exam. That's a big one. Patients, do not like getting this done, but this is the main way that they're going to be assessing the prostate, the size of the prostate. And in BPH, usually the prostate, when they do it, when the patient has BPH, apparently it's symmetrically enlarged and it's firm and it's smooth, right? So that's not a good thing. So they're looking at the size, symmetry, and the consistency to see whether or not there's anything bizarre there. So highlighting DRE, also highlighting the prostate-specific antigen PSA levels. So they're doing this specifically to make sure that the patient doesn't have other things like cancer, right? So that's why they're looking at your PSA levels as well. And then another big one would be the post-void residual, just to make sure that everything is okay in terms of the fact that the patient is able to void like they should be. So obviously other ones that they can do, so biopsies if they're needed, if they're suspecting other more complicated issues. Cystoscopies tends to be our go-to in terms of also looking in there. So for your purposes, um, PSA, post-void residual, biopsies if necessary, and the cystoscopies. So just know that these are some of the main tests that they're doing. But really the DRE is the one that they'll do in patients. So my dad actually had an experience with this. He called me up from Zambia, could not void, really, really scary situation for him. And he had to rush to the hospital. And basically all they did was they just straight cathed him. And then he was fine. And he's never had an incident like that again. So it's important just to teach patients about the possibility that this can happen, especially since it seems like it happens in some men, but not everyone, right? So just really, really important to address. In terms of the interprofessional care, so you just want to restore the bladder drainage, relieve symptoms, prevent or treat complications if they're present. And the treatment is basically going to be based on whatever the symptoms are that are there and whether or not the patient has any complications. Ideally, if your manifestations are minimal, they'll just watch it. They'll watch to see whether or not the symptoms get worse. And you're going to see that in the next couple of slides coming up. But you want to make sure that you're targeting the risk factors that we mentioned. So if we said things like diet, if we said things like alcohol usage, for our men that are older than 50, you want to make sure that they're really minimizing all of those risk factors so that they do not end up having BPH. So the conservative therapy, this is the one that's the watchful waiting, right? So if the patient has mild symptoms, so this is where your AUA score was about anywhere from 0 to 7. So primarily you're going to target the lifestyle changes. So you want to decrease any bladder irritants. You want to restrict evening fluid intake, right? You want to put the patient on a bladder retraining program where maybe like every 3 hours or every 4 hours you ask them to go on void, and you're making sure that they're getting the annual PSA and the DREs as well. All right, so there is a thing known as watchful waiting where you're basically making sure that, to see whether or not the patient's symptoms are going to get worse. And in my dad's case, like that happened, and it just happened at one time, and he's been fine ever since. He doesn't really drink things like coffee. So, I guess this is working for him. Doesn't drink like carbonated drinks or anything like that. But he also has he has diabetes, I believe. So he has to be really careful anyway. But I mean, for him, knock on wood, he's been fine. The what is this? The drug therapy. So two main classes. So 5-alpha reductase inhibitors and alpha adrenergic receptor blockers. So apparently they're more effective when used in combination. So we have a whole bunch of different drugs here. So you do not have to memorize this, but only see the ones that I gave you if they made it on your list. Okay, so these different types of drugs. The one that you're going to see a lot is the finasteride. Okay. All right, so all these different types. And another one that you may see a lot of is the doxazosin, Cardura. All right, so this one promotes smooth muscle relaxation and facilitates urinary flow through the urethra. This one, and you may see prazosin a lot too in the hospital, and Flomax as well. Okay, more medications. All right, so now we get into the minimally invasive therapies that may be targeted for the patient. So your minimally invasive therapies are becoming more common instead of the invasive treatments. All right, and obviously because you get few adverse effects from them, and the outcomes are comparable to invasive techniques. So once again, just know that these are out there. We are going to focus on TURP. All right, so invasive treatment of BPH involves surgery. Uh, Factors for choice of treatment depend on the size and location of prostatic enlargement, the age, and the surgical risk. So the indications for why we are going to be doing some of the more invasive therapies include decreased urine flow causes discomfort, persistent residual urine. So, patients voiding, but, every time we're going in there with a straight cath to assess the post-void residual, we're getting huge amounts of residual urine. Patient having things like acute urinary retention and things like hydronephrosis, right? So then we're worried, and then we're like, okay, well, then we kind of really need to do something else at this point. So this is the first example of an invasive therapy, and once again, we're just going to skip this one. So TURP is our gold standard for obstructing BPH, right? It used to require hospitalization, but that is no longer the case. They can actually do it on an outpatient basis. So all they're doing is they're removing the prostate tissue, the excess tissue that's there, through the urethra, right? And they're using something that's known as a resectoscope, all right? So we have a picture coming up. And this is our picture, all right? So there's this scope that comes in, and there's no incision that is made in order for a patient to end up with a TURP. So what I'm going to do is I'm actually going to upload another, I think it's a PDF that I have of what the TURP looks like, so you can get a better visual. So it's a transurethral resection of the prostate. So what you end up getting is a 3-way indwelling catheter with 30 ml balloon inserted for hemostasis to make sure that it stays in place and basically to facilitate urinary drainage. After the patient has had the TURP, they either have to get continuous or intermittent irrigation for the first 24 hours, especially if the patient is getting a lot of clots, right? It is considered the gold standard of treatment because in most patients they have an excellent outcome. All right. Most patients do well after this. They have decreased symptoms and they have increased urine outflow, which is the goal of the whole procedure. There not too many complications can happen, but what you do want to monitor for is something known as a TURP or TUR syndrome. And with this post-procedure, the patient may actually complain of things like nausea, vomiting, confusion, bradycardia, and hypertension. It used to happen because of hyponatremia, and it's because the bladder was being irrigated basically with what is known as an isoosmolar fluid. But now they're no longer doing that. They are actually adding in saline to the irrigation. So because they're adding the saline to that, you're not getting the hyponatremia anymore. So patients are really not getting this weird TURP syndrome. The other big thing you want to watch out for is the bleeding and the clot retention. So far you've heard me mention clotting, right? So that's the main issue with TURP. We're looking for clotting. So we've cut off this prostate tissue. We want to make sure that the urinary flow is there, right? So you're going to see in the other PDF that I post, you're going to see the whole process, and it's going to make sense. So we're worried about clot formation. All right, your nursing assessment for your patient. So a whole bunch of subjective data. So this is pretty much all the same things that you'd be worried about with somebody having any type of urinary problem. All right, so asking them a whole bunch of questions. Are they having things like problems with urinary hesitancy, urgency, frequency, all those types of things? Are they waking up at night to void? All those weird things. Are they having any bladder discomfort, right? Just really trying to collect all the information that you can. And some of your objective data, obviously they're male patients. You're going to be seeing a distended bladder. When they do the DRE, they're going to be getting particular results, all those types of things, okay? In terms of the nursing diagnosis that your patient may present with, so this includes things like acute pain, risk for infection, impaired urinary system function. All of this should be making sense for you guys. So if the patient is going to need a procedure, whether it's minimally invasive or more invasive, you basically have to do the whole thing with the pre-op teaching, and just so the patient is prepared for what can potentially happen after they've had the procedure done, right? So telling them what the goal is of the particular procedure, letting them know what to expect post-procedure, all of those types of things you'll be teaching the patient. And ideally, you don't want any post-op complications. That's what you want. You want the patient to be able to urinate like they should be. You want to be getting complete bladder emptying. And you also want to make sure, well, you hope that they'll be getting satisfying sexual expression once everything has been treated. So in terms of the health promotion stuff, you basically want to do early detection and treatment, right? So whatever that looks like for your patient. So we already know what the risk factors are. We already know that this is happening in men pretty much after the age of 50. So, we're just following whatever the guidelines are. So PSA screening, American Urological Association recommends men age 55 to 69 have screening every 2 years. Obviously, if maybe there's a history of this in your family, that may change in terms of how often they may be doing the screening, right? So if the patient has symptoms of prostatic hyperplasia present, then they're going to do other screening that needs to happen. But it's all about prevention, so avoiding any substances that increase prostatic symptoms, right? If the patient does have things like obstructive symptoms, putting them on the voiding schedule. So asking them to urinate every 2 to 3 hours, and when they first feel the urge, and that will basically decrease urinary stasis and acute urinary retention. So that makes sense. Teach the need for adequate fluid intake if it's not contraindicated, right? Making sure that they are not restricting fluids, because then that will put them more at risk for infection, and it's actually going to concentrate the urine too much, which won't be a good thing. All right. So pre-op care for TERP. So treat and manage UTIs, giving antibiotics, even prophylactically in some cases, encouraging high fluid intake, 2 to 3 liters per day, unless contraindicated. Restoring urinary drainage. So in some cases, they use a special curved tipped catheter that helps basically with promoting urinary drainage. If they can't get in there initially because maybe the prostate is really, really enlarged, they may have to use a rigid catheter. So there are different forms. One of them is known as a filiform. So like in an emergency situation where the urethra is really blocked off, they may not be able to use just a regular catheter to straight cath the patient. So they have to use a rigid one. And, obviously using aseptic technique to prevent infection, right? So all of that makes sense. Okay. So post-op care for TERP, assessing for any complications, and the main ones are hemorrhaging, bladder spasms, urinary incontinence, and infection. In terms of pre-op care for TERP, so providing patient and partner the opportunity to express concerns about sexual function, and making sure for sure that you've told the patient about any complications that may happen. So the decreased or absent ejaculate volume, just know that may be a possibility in some patients. And then the retrograde ejaculation. So retrograde meaning that the sperm will be going backwards, right? So when they're ejaculating, instead of going forward, it's going to be going backwards. And all that happens with that. Okay, so my hubby's laughing. All that happens is that when the sperm goes backwards, they pee it out later. So nothing major, all right? They're still ejaculating. Post-op care for TERP. So the biggest thing, like I said, is making sure that we don't have any clots. So removing blood clots and ensuring the drainage of the urine. So instilling and withdrawing 50 ml irrigating solution. In some cases, this can cause bladder spasms when they're doing the intermittent irrigation and they're doing it manually. So just know that that's a possibility. So post-op TERP, that is the biggest thing. This is the biggest issue. We don't want to see any clots, right? So in order to ensure that there's no clots, we are going to be irrigating the Foley catheter that's there, all right? So we can either be doing this manually, doing this intermittently or we'll be doing it continuously. So this is known as continuous bladder irrigation. So you're going to see in my other picture that you're going to have this big bag hanging, and it's going to have saline in it, and it's going to be flowing into the patient. All right. And it's basically going through the bladder. And then you're going to see that there's a drainage bag at the bottom as well. All right. So they can do this two ways. So either manually, intermittently, where they're irrigating it, right? And it all depends on how many clots they're seeing in the patient. So one patient, they've done the surgery, and initially, yeah, it's blood tinged, it's a little pink tinged. You expect that in the first 24 hours, no big deal. But the main thing is you're looking out for is the clots, right? Important thing with TURP is you're monitoring also how much fluid you're putting in and how much is coming out, because all of that matters. So strict intake and output. If you're putting in all this fluid to irrigate and none of it is coming out, well, there's a blockage there. Something is wrong. And that could be one of the main reasons why your patient is having something like bladder spasms, right? So in order to correct that, you could potentially manually just irrigate it if they did not have a CBI, if they did not have a continuous bladder irrigation, right? Some patients, maybe for whatever reason, for them, you do the surgery and they have a lot of clots. You see them. So for them, they'll decide right off the bat, we are going to do continuous bladder irrigation. So this is why you see the bag hanging, and then another bag at the bottom collecting whatever urine and the fluid that's coming out. Your job is to keep track of the intake and output so you can assess exactly how much urinary output the patient is having. So we'll go through this with the other picture that I'm going to have for you. All right, so know that it can be intermittent or it can be continuous. All right, so ideally we want light pink without clots, right? And if your patient is on continuous bladder irrigation, so they're getting a continuous bladder irrigation, you can increase or decrease the rate for the irrigation depending on how much clots you're seeing or how pink or how red your output looks like. All right, so if you're seeing clots, you're going to be increasing that irrigation. So in some institutions, they may have standing orders to say, hey, if you see this, do X, Y, Z. Some places they may not, and they may want you to call the doctor to let them know that you're seeing clots. Therefore, let them know like how much do I need to increase it by. But across the board, like when I worked on the med-surg floor, and you're going to see this sometimes on med-surg, just regular unit, really that was up to us in terms of regulating. Like if I saw the clots, I would basically just increase the irrigation, but I would call the resident to say, hey, I was seeing a lot of clots and I've increased the irrigation. So this was actually like a very nursing kind of specific thing that we did here. All right. So assess the patency, monitor intake and output. If it's blocked, like if you see that this irrigation is coming in, but nothing else is coming out, that's a problem, right? Then you want to notify the healthcare provider. If it was an intermittent irrigation, so where they didn't have the big bag hanging, and you notice that the post-op your patient in the Foley catheter bag, you're seeing a whole bunch of clots. So then you go in there manually to irrigate it, right? You draw up some 50 mLs of irrigating solution. So you go in there to irrigate it, and you've irrigated it, and still you're not seeing any outflow of urine. Then you know that something else is happening, and maybe it's too big of a clot. Then once again, you are going to be notifying your healthcare provider. All right. All right. So you want to make sure that we're not, the patient is not ending up with things like sepsis post-TURP, right? So minimizing the risk for bladder infection. So making sure we're using aseptic technique and making sure we're having things like a closed drainage system. So blood clots are expected 24 to 36 hours post-op. Assess for large amounts of bright red blood. And so you're monitoring for hemorrhaging basically, right? So this can happen. Maybe there's a catheter displacement that's happened. Maybe there's a dislodgement of large clot. Maybe there's an increase in abdominal pressure, right? So you're monitoring for hemorrhaging. So we expect some type of clots to be there, but not past the 36 hours, right? So if we're doing irrigating, et cetera, everything should be fine. After this 36 hours time frame, and then we're still seeing a lot of blood clots, we're getting worried. And then we're thinking, okay, maybe the patient may be bleeding at the site where they cut, right? Because they're supposed to have the hemostasis, where the bleeding should stop. The tissue that they've cut off, like that should stop. Okay. All right. So like we said, maybe the catheter basically displaced the one that they had put in there to basically maintain the hemostasis. All right. So in some cases, they may add traction to it if that's needed. I never saw traction the whole time I worked. It was literally just the CBI bag, and that was it. Nothing else going on. So other reasons why they may get complications if the patient has increased intra-abdominal pressure. So they want the patient to avoid prolonged sitting or walking and any weird straining like Valsalva maneuvers or any of that. So we don't want any of that happening. Bladder spasms primarily because there may be some clotting in there. You don't want the patient to be urinating around the catheter. So that I guess the patients can force the peeing around the catheter, which that's weird, which I've never seen either, because the fact that the catheter is in place, really the Foley should be fine and it should be able to get rid of all the urine that's in there. So I don't know how there would potentially be urinating around the catheter. So treatments for spasm and pain, so things like belladonna and opium suppositories, antispasmodics, and things like relaxation techniques also. All right. All right. Ideally, we're taking the catheter out after 2 to 4 days. If we take it out and the patient is unable to urinate, then we will have to reinsert the catheter. Some patients may have to self-catheterize until they're able to basically void by themselves. All right. Some of the other things a patient may have are things like urinary incontinence or dribbling. So with that, you're going to be teaching them Kegel exercises to basically strengthen the sphincter tone. It may take a while for them to get their continence back. So apparently that could take up to 12 months. If the patient is suffering from things like dribbling, then there are different things that they can put on. So there are things known as a penile clip, which I've never seen. But they can also put on like a condom catheter or incontinence pads, so that basically they're not, they're not walking or sitting at work, and then next thing you know, there's urine coming out, right? So they can use all of these things to basically decrease the embarrassment from that. So imagine having this discussion with your patient, right? This, just having this discussion would be perplexing. So some more post-op care for TURP, monitor for signs of infection. So avoiding any type of rectal procedures like taking temperatures rectally or anything like that, right? None of that is going to help, right? Preventing straining, so dietary interventions, giving the patient things like stew softeners. Okay. So in terms of discharge planning, home care, and patient teaching, you are basically, looking at how the patient is and just teaching them everything about preventing infection, making sure they're drinking enough, making sure they're voiding properly, preventing constipation, avoiding heavy lifting, those types of things, right? Refraining from driving or intercourse soon after the TURP procedure, all those types of things. Discussing changes with patient and partner, for example, about things like retrograde ejaculation, giving the patient sexual counseling if erectile dysfunction becomes a chronic issue. Apparently, this may take up to 1 to 2 years to return to normal function. Teaching them about the bladder capacity, that it may take up to 2 months to return to normal. Encouraging the patient still to drink 2 to 3 liters of water every day. And to void at least every 2 to 3 hours. And then making sure that they're going for their yearly digital rectal exam. All right. And basically, you want to, when you're evaluating, making sure that you've reached your outcomes in terms of surgery. Okay, so that's all I have for BPH, and I will be uploading the other picture for you.